Hi guys, here is your last chapter summary for this class, chapter 19, dealing with death and bereavement. So death is a biologic fact, but it has many social, cultural, historical, religious, legal, psychological, developmental, medical, and ethical aspects as well. And that's what makes it so difficult to deal with sometimes. There's definitely cultural context to death. Different cultures view death and how we grieve and mourn and deal with all of those things a little bit differently. So customs regarding remembrance and disposal of the dead, transfer of possessions, expression of grief varies a lot from culture to culture. But expressions of grief, loss, anger, and fear are common among all cultures. The mortality revolution, a lot of historical changes have taken place since the 19th century. Advances in medicine and sanitation, new treatments for diseases, and better educated, more health-conscious population have brought around what's called a mortality revolution. People are living longer. We're able to keep people alive longer. The top two causes of death in the United States for people over the age of 65 are heart disease and cancer. And thaniology is the study of death and dying. Care for the dying. One option that is available for terminally ill patients is called hospice care. It's personal care for the patient and their family, usually for those who have 6 months or less to live. It can take place at home, in a hospital, at a hospice center, or a combination of facilities. And the main job here is to provide what we call palliative care. It's to relieve pain and suffering, control the symptoms, alleviate stress on the family members, and attempt to maintain as much quality of life as possible. It is not intended to cure or reverse the disease. So this is for people who know that the end is near. Facing death and loss, there are physical and cognitive changes that happen before death. There's something called a terminal drop or decline, which is frequently observed, a decline in cognitive function near the end of life. Dementia will sharply increase that rate of decline. But by age 100, most people are going to experience functional declines even without an identifiable illness, and then usually go on to die a natural death. Confronting one's own death, Kubler-Ross proposed 5 stages, which are similar to the stages of grieving, and they are denial, anger, bargaining for extra time, depression, and then finally acceptance. As far as grieving goes, grief is defined as an emotional response experienced in the early phases of bereavement. Bereavement is loss due to death of someone to whom someone feels close to, and the process of adjustment to that loss. And grief work is working out the psychological issues connected with grief. Shock and disbelief. There's usually an initial numbness followed by sadness and frequent crying. This can last for several weeks after the death of a loved one. Preoccupation with memory of the dead person. You start to come to terms with the death, but still have trouble accepting it. This could last 6 months to 2 years. And then final is resolution, where the bereaved person renews interest in their everyday activities, and memories of the dead person brings fond feelings, not always sadness. There are absolutely variations to grieving patterns. Recovery can go from high to low distress. Delayed grief is elevated initial grief and symptoms that gradually worsen over time. Chronic grief is when the mourner remains distressed for extended periods, and resilience is when the mourner shows low and diminishing levels of grief. Attitudes about death and dying across the lifespan. As far as childhood and adolescence go, most parents begin to explain the concept of death to children around the age of 3. They teach that death is irreversible, that it's final, someone won't come back to life, that it's universal, it happens to everyone. That it's non-functional, meaning you lose all bodily functions, and it is inevitable. At some point, everyone will die. The afterlife is taught as part of many religions, and so a lot of people do believe that there is some sort of something after death. And death is difficult to understand, especially for children. There is a better understanding if it's talked about with parents. But again, because it is a difficult and touchy subject, parents often don't discuss death with young children. Children can have difficulty understanding and expressing their grief. There is a chart found on page 563 in your book that talks about different age groups and how they might express their grief in different ways. Parents can help children deal with grief by having open and honest conversations about death, reassure the child that they will continue to be cared for by loving adults, that they try to make as few changes to the daily routine as possible, and encourage the child to talk about their feelings. Adolescents often turn to their peers for support when they lose someone close to them. Young adults diagnosed with terminal illnesses are often angry and distraught at the thought of not being able to live out the rest of their life. In middle age, the body starts to send you signals that you are not as young as you used to be. And especially after the death of both of your parents, there's a new awareness that you are now the older generation and the next in line to die. Older adults often have mixed feelings about dying, ranging from fear and anxiety to relief. The terror management theory, no matter what the age, death is distressing and has the potential to result in declines in well-being and increases in anxiety. There are common emotional and psychological responses to death, and some people handle this by becoming more religious. People who have high self-esteem generally have less anxiety when it comes to death, and seeking comfort from loved ones helps as well. Significant losses can happen at this, or that's what we're talking about with death. Surviving a spouse, women are more likely to be widowed because they are typically younger than their husbands, and women live longer than men. The stress of losing a spouse can affect both physical and mental health. Becoming widowed is associated with a 22% increase in risk of death. Bereavement can also lead to symptoms such as headaches, memory problems, dizziness, difficulty concentrating, indigestion, loss of appetite, and chest pain. Also higher risks for disability, depression, drug use, anxiety, insomnia, hospitalization, and even death. And we mentioned that in a previous chapter. There are studies that have looked at lifespan after the loss of a spouse and how it's often diminished. For women, death of a spouse can create an economic strain, and for men, it can create a strain of social isolation and loss of emotional intimacy. Losing a parent in adulthood, bereaved adult children show impact on well-being even 1 to 5 years after the death of their parent. Decreased stress if parents left instructions regarding medical treatment, funeral arrangements, and distribution of assets. And the parent may be the bond that kept siblings together, so after their death, they may drift apart. Losing a child. Parents are rarely prepared for the death of a child. We don't expect that our children will die before we do. It can place a large stress on a marriage. If the marriage is strong, it may bring the parents closer together, but it may also weaken or destroy the marriage. There's a heightened risk for being depressed or hospitalized for mental illness after the death of a child. And women tend to grieve more than men, but this generally diminishes over time. Also, mourning a miscarriage. An estimated 1 in 3 pregnancies end in miscarriage. And there is a somewhat of a belief maybe that the loss is not as significant as losing a living child, but it is still a loss nonetheless. Many people don't tell others about their pregnancy until after the first trimester when miscarriages are not as common. So family might not even be aware that support is needed. Grief, depression, guilt, isolation, and sadness are normal reactions to a miscarriage. And there is an increased risk of divorce following a miscarriage. Medical, legal, and ethical issues, including the right to die. First, we'll talk about suicide. A suicidal person may be considered mentally ill, but some people consider an adult's decision to end their own life as a rational decision. About 800,000 people commit suicide every year. That's worldwide. The highest rates are in elderly and men greater than women. The suicide rate in the United States is increasing, and the statistics may actually underestimate the number. Things like accidental overdoses and accidents aren't always ruled suicides or counted as suicides, and also suicide attempts are not counted in this figure either. More women attempt suicide, but more men are successful at taking their own lives. The rates of suicide using firearms is higher in the United States than in any other country, and gun deaths by suicide outnumber those by homicide. Suicide rates are highest in Native American and Alaskan Natives, followed by whites, Asian Pacific Islanders, African Americans, and Hispanics. The loved ones of someone who commits suicide often have a harder time dealing with their death. They can feel guilt, shame, isolation, and rejection that maybe they should have seen the signs. And speaking of that, Table 4 on page 570 in your book lists the warning signs of suicide. Euthanasia falls under this right to die sort of category. Euthanasia literally translates into good death, and it is intended to end the suffering or allow a terminally ill person to die with dignity. There's passive euthanasia and active euthanasia. Passive is withholding or discontinuing treatment that may extend the life of a terminally ill person, such as medications, life support, or feeding tubes. This is generally legal. And active euthanasia is deliberate action taken to shorten the life of a terminally ill person, also known as mercy killing, and this is generally illegal. Advance directives is a document specifying the type of care wanted by the maker in the event of incapacitating or terminal illness, and this is legal in all 50 states. Durable power of attorney appoints another person to make decisions for you should you become incompetent or unable to do so for yourself. Assisted suicide is when a physician or someone else helps a person to take their own life. It is legal in 9 states and Washington, D.C. The American College of Physicians and the American Medical Association both oppose physician-assisted suicide. It goes against the Hippocratic Oath. Some of the pros or arguments for allowing assisted suicide are that it allows for autonomy and self-determination. It preserves the dignity of the dying person, and that a doctor is obliged to take all necessary measures to end a person's suffering. Safeguards can be put in place in order to prevent abuse. The cons, or arguments against allowing assisted suicide, are that taking a life is wrong, protection for the disadvantaged. They're afraid that some populations may be sort of unfairly targeted or sort of encouraged to take their own lives. Possibility of misdiagnosis, future availability of new treatments. You wouldn't be around for those. And helping someone die goes against a physician's oath. And lawsuits if families disagree about what a person should do. In 1994, Oregon passed the Death with Dignity Act and became the first state to legalize assisted suicide. Since that time, they have found that there have been improvements in palliative care and more deaths at home versus at a hospital. From 1998 to 2018, 1,459 terminally ill patients took their own lives. The reasons that they cited for this were they were afraid to lose autonomy, they were unable to participate in enjoyable activities, and the loss of dignity. The median age at death of these people was 74. They were mostly all white, well-educated, dying of cancer, on hospice, and had medical insurance. 84% of Americans support a terminally ill person's right to decide, and 70% agree that there are some circumstances where a person should be able to choose to die. And then the book finished up with finding meaning and purpose in life and death, and they talked about what's called a life review, which is reminiscing about your life in order to see its significance, and we see this commonly in old age. So that is it. You're all done. Congratulations. Let me know if you have any questions.